All right, welcome to This Explainer. Today, we're diving straight into a fascinating and honestly historically misunderstood part of the human body, female anatomy. We're going to map out the real science. We'll start right at the external structures of the vulva, navigate the hidden depths of the clitoral network, and travel along the vaginal wall. And the whole point of this spatial journey? To actually understand the precise clinical mechanics of the G-shot procedure. So if you've ever wondered exactly where this injection goes and what specific tissues it interacts with, you're in the right place. Let's get into it. So here's our quick roadmap for today. We'll kick things off by mapping the vulva, then we'll uncover the clitoral iceberg, and follow that up by demystifying the G-spot. After that, we'll look directly at the clinical side of things with the G-shot procedure, and finally wrap up with anatomy meets aesthetics. Starting off with Section 1, Mapping the Vulva, the External Foundation. We always need to start at the visible exterior to set a solid baseline for the complex internal systems we're about to explore. When you look at the foundational layers here, it's a really incredible design. On the outside, you've got the labia majora. These are those larger outer folds made mostly of loose tissue, smooth muscle, and fat pads. And their main job? It's pure protection. They're basically cushioning the delicate internal structures from daily friction. Now moving just inside, we have the labia minora, the inner lips that directly border the central vaginal opening. But here's the crucial takeaway. Clinical anatomy shows us that these external parts aren't just passive biological shields. They contain complex sensory and erectile tissue. They're highly responsive, and they set the perfect stage for what lies beneath. Which brings us right to Section 2. The clitoral iceberg. And trust me, there is way more here than meets the eye. It is honestly wild to look at the medical history here. For literally centuries, the clitoris was either totally overlooked or just completely misrepresented. I mean, ancient Greek and Roman doctors viewed the female reproductive system as just kind of a passive, inverted male anatomy. And later, you had figures like Sigmund Freud dismissing clitoral stimulation as immature. Unbelievable, right? It actually wasn't until 1998, 1998, that Australian urologist Dr. Helen O'Connell used MRI technology to fully and accurately map clitoral anatomy. Just to put that into perspective for you, we literally put a rover on Mars before we had a complete accurate medical map of female anatomy. And that late discovery brings us to a massive realization. The ancient Greek word clitoris meant little hill, but modern mapping shows us it's not a little hill at all. It's a mountain. It's a huge internal structure of erectile tissue that averages about 4 inches or 10 centimeters in total length. What we see on the outside, that is quite literally just the tip of the iceberg. 10 centimeters of highly sensitive tissue hidden right beneath the surface, completely overturning all those ancient medical assumptions. Now, here is where the science gets truly mind-bending. 8,000. That's the number of nerve endings packed into just the external clitoral glands alone. To really grasp how dense that is, that's roughly double the number of nerve endings found in a penis. And remember, its only biological function is sensory pleasure. So having 8,000 nerve endings clustered into such a tiny external point, that creates an intensely concentrated sensory bandwidth. It's a hyper-responsive gateway. But let's look at what's going on behind that gateway. Beyond that visible glans, this clitoral iceberg extends deep into the body. You've got a firm shaft that reaches inward toward the pubic bone. And from there, it actually splits. It splits into 2 long legs called crura, which can stretch up to 5 inches long. Imagine a shape kind of like a wishbone, arching and extending deeply into the pelvic cavity. Right alongside those legs are the vestibular bulbs, which literally cradle and hug the vaginal opening. So during arousal, this entire massive wishbone network of internal tissue engorges with blood, swelling and expanding significantly. So with that deep internal network in mind, let's move to Section 3, demystifying the G-spot, as we venture inside the vaginal canal. All right, so if we travel roughly 1 to 3 inches, or about 3 to 5 centimeters inside the front or anterior vaginal wall, we hit the Grafenberg spot, the famous G-spot. It's named after Dr. Ernst Grafenberg, a gynecologist who studied the urethra's role back in the 1950s. But here is the most critical clinical takeaway. The G-spot is definitively not a separate, distinct organ. It's not some hidden magic button. Instead, it's defined as a dynamic, highly sensitive region of tissue. What's actually happening behind that front vaginal wall is this incredible anatomical convergence. This spot sits exactly where the internal legs and bulbs of the clitoris, that sweeping wishbone shape we just talked about, press up close to the vaginal lining. And it doesn't stop there. It also includes the urethral sponge, which is a dense network of erectile tissue surrounding the urethra, plus Skene's glands, sometimes called the female prostate. So when you realize the G-spot is actually this complex merging of concentrated nerves, active glands, and erectile tissue, well, it completely explains why physical sensitivity here varies so wildly from person to person. It's a very busy anatomical crossroad. Now that we have this precise anatomical map down, let's jump to section 4 and look at the clinical application, the G-shot procedure. So what exactly is it? Essentially, the G-shot is a minimally invasive clinical treatment. A medical provider injects a soft tissue dermal filler straight into the submucosal layer of that anterior vaginal wall. And the submucosal layer is just the connective tissue resting right beneath the surface lining of the canal. By injecting directly into that G-spot convergence zone we just mapped out, the whole goal is to temporarily plump the tissue. It makes that specific area thicker, more prominent, and basically much more accessible to direct physical stimulation. The procedure itself usually uses a cross-linked hyaluronic acid filler. And if that sounds familiar, it's because it's very similar to what's used in everyday facial aesthetics like lip fillers. Why hyaluronic acid? Well, it's a substance that naturally occurs in the human body, and it's incredible at binding to water, making it perfect for safely plumping tissue. This specific injection plumps the internal tissue to about the size of a 5p coin. By thickening that submucosal layer, the tissue projects further out into the vaginal canal. And since hyaluronic acid is natural to the body, it just naturally metabolizes over time. So the augmentation is temporary, with results usually lasting around 4 to 5 months before fading. Let's actually walk through the steps of what doctors often call a lunchtime procedure. First up, the provider does a routine pelvic exam. By applying a little bit of pressure to the inner vaginal wall and lower abdomen, they precisely locate the patient's exact G-spot region. Step 2, they apply a highly effective local anesthetic, so the whole target area goes totally numb. Third is the hyaluronic acid injection itself, and this is incredibly fast, usually taking under 10 seconds. That speed is a huge part of the appeal. And finally, step 4, 0 required downtime. Patients can literally hop off the table and go right back to their normal daily activities. Let's zoom out now to our final stop, section 5, Anatomy Meets Aesthetics, where we look at the broader medical context of all this. The anatomical rationale behind the G-shot isn't just guesswork. It's rooted in clinical research. Studies in journals like the Journal of Sexual Medicine point out that folks who naturally have thicker tissue in this specific anterior wall region are often more likely to experience intense physical stimulation. Why is that? Well, thicker tissue in this nerve-rich plexus essentially acts like a bigger physical target. It bridges the gap. It makes that dense network of the urethral sponge and the internal clitoris much easier to engage physically. The G-shot is simply aiming to temporarily mimic that thicker anatomical state. But we absolutely have to talk about the clinical realities here, because at the end of the day, this is still a medical procedure. First off, because the internal clitoris and urethral sponge vary so drastically in size and depth from person to person, the results of a G-shot vary greatly too. It is definitely not a magic one-size-fits-all fix, and it is explicitly not designed to treat underlying psychological or sexual dysfunctions. From a strict medical standpoint, even though it's highly localized and minimally invasive, you can still see minor side effects, things like brief mild spotting or tenderness for a day or two. As we wrap up this explainer, I want to leave you with one final thought. We just learned that the complete, accurate mapping of the clitoris, a massive, incredibly complex organ, only happened in 1998. 1998. It really makes you wonder, as science finally continues to pay close attention to the intricacies of female anatomy, what other wellness frontiers and profound anatomical marvels are just waiting to be discovered? Thanks so much for exploring the science and structure of the human body with me today.